that, or you have to keep drawing back on what you've learned in immunity. Okay, y'all just went over immunity. You went on your, and when you start thinking about what the jobs of the cells do, you will have a better understanding of why HIV happens. Okay? I've actually put just a little bit of blurb there with the immunity center just to remember, or just to sort of spark your memory a little bit about what the actual immune system does for you. You've got to remember that our body knows itself. And when there's anything that's not in there, comes into our body that is not recognized, what does our body do? It starts to attack it. And it's protecting us, isn't it? So we know that with a patient who has HIV, we know that there's something abnormal in there. So what type of cells are going to start working when a patient's going to be infected?
T cells.
Our T cells, exactly, which are a form of white blood cells. Right, they're a form of white blood cells. So our T cells are automatically going to say, woohoo, I don't like you. And we'll see what's happening in just a little bit when we talk about actually our T cells and what they do. Their major thing is to fight infection. That's what they're going to do. That's their job. And you can see as things start happening with this HIV, is they're going to start working. And I can bet, do you think they're going to win? No. Because it's really a fight, isn't it? I mean, it's a fight within their body. So a patient who's been infected with the HIV virus, their T cells eventually are going to lose the battle. So you know our patients who get infected with HIV are eventually going to have AIDS, and eventually going to die. Because there is no cure at this point for HIV. So you know that our patients are dying. Because our T cells cannot hang on to it. They cannot fight it off enough. Alright, so HIV, you know that there is a difference between HIV and AIDS. There is a difference, right? You know that? Okay, HIV means that I have been infected with that virus. HIV is a retrovirus. Does anybody know what retrovirus means? No? Do you know what a retrovirus is? When you think about and I think this is one of the fascinating things, and I think me and some of my club were talking about that yesterday. With a virus, or with our cells, do you have a hard time comprehending really what happens in a cell? Yeah. Is that like beyond your thought process sometimes? I mean, it's just like, how in the world does this little tiny virus make its way in there and start changing stuff? I mean, it just fascinates me. So let me back up to I don't even think I wrote retrovirus on any of that. But what happens is when a retrovirus comes in, it's got RNA. It comes in with this virus, this HIV virus, has its own RNA. And what happens is, to make it a retrovirus, the RNA is changed to DNA. That's why it's a retrovirus. It has its own RNA and it's changed to its DNA. Can it do it by itself? No. It's got to have an enzyme called reverse transcriptase. State Board of Nursing wants you to know that retrovirus is changed from RNA to DNA by reverse transcriptase. That is the enzyme. Now, a lot of this little things that happen in the AIDS progression is not understood. This one is. The reverse transcriptase, it has to have that enzyme to make that turnover from the RNA to the DNA. You know that, let me just say this. Does everybody that has HIV have AIDS? No. That is another vital part of you understanding the AIDS and the HIV progression. And we're going to go over that very in depth in just a little bit. But just know that just because they have HIV doesn't mean they have AIDS. AIDS is the most common secondary immune deficiency disease in the world. It is a virus, and the biggest thing that virus is doing as it comes into the body, it starts looking for someone or looking for something to be bad with it. The way I like to make that analogy is when you do something wrong or your kids do something wrong, don't they always want to grab somebody else to do it wrong with them? And that's exactly what that virus is doing. It's coming to that virus and it's saying, come on, Amanda, I'm being bad, you do it with me. And it's going to grab everybody that it can grab to be bad with it. And that's the bad part over it, because it wants everybody to be bad, so it's got to be looking for a host cell. So you've got a good little cell over here, and it's, Miss Prissy, and she's got everything going on, and here comes the bad person. Here comes Amanda. Amanda's been bad. She's got that virus. Don't you think she's going to go over to that little Prissy cell and say, come on, girl, me and you are going to be bad together? And that's exactly what happens with that. And they want to find every host cell they can find to take over. And eventually, at the beginning, it starts reproducing real quick. And by the end of a patient's life, they have every one of their host cells are infected with that virus. And that's what makes the disease progress. All right, so let's talk about how it makes its little connection. Okay, we know that the virus comes in and it's looking for a host cell. The host cells are going to be our T cells or our CD4 cells. So that HIV is trying to find a CD4. Do y'all know what a CD4 is? It's a T cell, exactly. So it's CD4 and T cell. But what does that CD4 do?
It controls everybody. Yeah,
it controls it, but it also does what? That's the one. It's like an initiator, exactly. So it's going to say, woohoo, this CD4, he's infected that T cell, and that CD4 is coming in there, and the CD4 is going to be the one running with it. And he's going to go try to get everybody he could possibly get to be bad with him. Okay, so they're going to go together. And what happens is, it's like a lock and key. If you remember, when it first starts, because there's all these little proteins on this, you know how our cell looks good and smooth, a normal cell? Not an HIV cell. An HIV cell has lots of little, I think of a porcupine. It probably doesn't look like a porcupine in the pictures that you've seen, but I think about I think it's got all these little sticky things on the outside of it, so when it goes and hits up against another cell, that porcupine stick goes into that cell and they come together. So when they first meet, that's the attachment part of it. So think about the little proteins. The proteins is what drives them to a host cell. So it's like the porcupine little things are antennas. And here's the little CD4, the T cells, they're running, or the virus, and it's running around to try to find somebody. And as soon as it says, okay, Amanda, you have now stuck Robin. And you two are going to come together. And then now, you got to have that CD4 cell. You got to have that CD4 cell to start reproducing the virus. It's like a lock and key. Once it goes in, and that lock is turned, that cell will become an HIV infected cell. Okay? So the attachment part of it, because once it goes in, once you put that key in a lock and you turn it, yeah, we can pull that lock, that key out with HIV. It is locked and there is no key to get it out. It is in there, and it's got it infected. Ooh, wrong way. Ooh, I am going backwards. Help me here. What is wrong with this thing, or is it just me? I told y'all I'm not good at this thing. Okay. All right, be easy with me. All right, so now the porcupine has got into, it is connected. Amanda and Robin are now connected through that lock and key, and then Amanda is going to inject her infected protein into Robin. That is the fusion of it. So the cell membranes will then become enveloped together. So the outer part of that cell membrane is now, Robin is now going to have that protein of the HIV virus in her as well. So that's the fusion part of it. The uncoding. When we talk about what is needed inside of there, because you know that Amanda has an RNA, right? And then when she infuses that RNA, she's got to now, or she doesn't, but Robin is going to start changing her RNA to the DNA of the virus. Exactly. So once she starts changing hers, then she's going to be that infected one. This is the conversion of it. Now, this step is vital in the treatment of an HIV patient. One of the major treatments, and we're going to talk about it a little bit later, but one of the major treatments of an HIV patient is I want to make this step, RNA to DNA, not happen. And the only way I can make it not happen is through medications. So if they do their medications like they're supposed to, and I'm going to strictly tell y'all about these medications in just a little bit. If we can get them to, in an early stage, and get them on the medication, the conversion of RNA to DNA can be halted. Now, does that mean that that patient will no longer have AIDS?
No.
That does not mean that. It just means that it's going to help in stopping the progression of the cells attacking every one of them. So it's going to slow the process down a little bit. It's still going to happen, but hopefully if we can get it at this point, it won't infect as many cells, so the patient will have a longer time to live. That's our goal. Because once they get HIV, they're always going to have HIV. All right, so this, now, reverse transcriptase. is the only way that that RNA can be converted to the DNA with this enzyme that we just talked about just a minute ago. So you're going to see how that medicine is going to work on the reverse transcriptase in just a little bit. Are you with me? Is this a little bit easier to understand than your book? I thought your book was a little bit confusing. So I've tried to break it down just a little bit. So if I can make, when you're thinking about HIV, the goal of it is I've got to be able to decrease the changes of the RNA strand to a DNA strand with the reverse transcriptase. So I need to block that reverse transcriptase, right? I need to halt that. So if there's some way I can halt it, then hopefully I can increase or decrease the time and the replication of more HIV virus cells. Does that make sense? I've got a few little blank looks on your face, so are you with me? Okay. All right, and then step 5, the integration. And this is when it starts doing the same thing. So now Amanda has infected Robin. Robin has released her reverse transcriptase, and she has converted her RNA to DNA, so she is a full-blown HIV cell. And where do you think she's going now? She's going to find Pat. And she's going to say, come on, girlfriend, you're going to be ugly with me too. And so she's going to do the whole process over with her. Now, at this is where it's a little bit shady, but I'm seeing more research coming and adding in different types of other kinds of enzymes and other kinds of cells and stuff, like the 40 and all that kind of stuff. I don't want you to get into that. That is too deep. That's going to be a genetic issue. I don't want you going there. I want you to go HIV, reverse cell, lock and key, reverse transcriptase. Don't worry about the others. CD4s.
Does it start with just one CD4, or does Robin become a CD4 after she's converted her RNA?
What she converts that, she's another CD4 and she's gone.
So she starts as a normal cell, and then after Amanda gets a hold of her and she does her stuff, she becomes a CD4 to go out and do the same.
Right.
Okay.
And you know, their CD4s are looking for host cells. You know what a host cell is? Just a normal cell. Just any normal cell that's willing to say, ha ha ha, I might want to be bad with you too. Oh, honey, once they just get to see Amanda, ain't gonna stop with this Robin. Okay. Robin's coming to get, Amanda's coming to get you too.
So Amanda doesn't die. She keeps on going.
Oh, no, she don't die.
But Robin also goes to others.
Right, so now you've got Robin, you've got Amanda going out for everybody, and you've got Robin. And then as soon as you infect Pat, and you infect Jennifer, you got 4 going out. So we've got, and we are going to try to get as many people as we can to be on our side.
So maybe going a little ahead, but is that how it progresses from HIV to AIDS? Without treatment of that? Stopping that?
Okay. Yes.
Okay.
Because what's going to happen, and I can go ahead and probably go here. So what's going to happen is, once they start infecting everybody, what do you think those T cells or the CD4 cells are going to do when we draw their blood? They're going to look like CD4.
So they're going to think that
they're going to change, and the lab value will then go down because it's not going to be a normal CD4 cell. So when I draw their blood and I draw the CD4 level, we're looking for a normal CD4 cell that does not have HIV in it. So when when you draw blood and they put it under the microscope and they're looking, and it's just like sickle cell. When you draw your blood, when you look in there and you look for cells that are normal, sickle cell are not normal. When they look in the microscope, what is going to be different when they look under there and it has a cell of a normal cell and then an HIV cell?
It's gonna have
What's it
RNA.
going to make? What's it going to look like?
It's gonna have RNA in it, right?
It's going to have RNA. No, it'll be changed to DNA. Then, but what does the outside of it look like? Like a porcupine. Right, because now Amanda was porcupined out. She has now made Robin porcupined out because she has made that transformation, and she is a porcupine. So when I look under the microscope, I'm going to see cells that have the protein sticking out on them. And so when I count, or when the person counts it, are they counting the CD4 levels that have the porcupines? No.
Because they're HIV.
Because they're HIV, they're not a normal CD4 cell. So it's going to make the CD4 count do what? Go down. And that's the way we're going to tell if it transfers from HIV to AIDS. Certain number, exactly. And that number, and we'll talk about that number in just a minute.
So which stage does it, okay, the viral when does it let go and go to another cell? So that cell gets bigger, matures, and then goes and becomes male.
When does it unlock? When it's made that actual transformation from RNA to DNA. And then it breaks off with the reverse transcriptase, right? Because we've got the reverse that made the transformation. And then it starts doing the integration. That's not the one I really want you to worry about. Let's go to 6. Oh. So this, and I think I'm going to answer your question right now, but I think Adam had a question. Did you have a question?
Well, the question was more of an analogy.
Okay.
So basically, that HIV virus is kind of like the zombie infection. It starts with one zombie, they go and bite somebody, and then it just keeps spreading.
Exactly. Because we always want, when we're bad, we want everybody else to be bad with us. So we want everybody to go out and say, okay, I want you to join me. But Jennifer, what you're talking about is the final part of it. When they actually break off from each other and go. You've got to have another enzyme that is in that cell with the reverse transcriptase, and it's protease. So when that is actually excreted, then you have now made a new assembly of an HIV virus.
So that one is out.
So that one is now released, and Robin is now, from Amanda, going to say, but you got to have that protease to make it separate for the last time, or because they're together. They're friends. Amanda's going, come on, girl. And Robin's probably saying, no, I don't want to do this. This is not right.
Now, who carries the protein?
The virus. I mean, the host. The host has the protease, and when they come together, they release it. It's almost like, I don't really want to, but I'm going to anyway. So it releases that, and then that's when it makes that final separation to go off and say, now Robin can go off, and she's going to get Pat. And then they're going to go through theirs.
So really, HIV can't do anything without a good CD4 cell.
Exactly. It has to have a host cell. And with someone who has a good immune system, let's say Amanda's got her porcupines out, her sticks out. Whitley has a tremendous immune system. She's never sick. Amanda's going to start plugging into her, and her immune system's going to say, You ain't coming in here. And so she's going to bounce off. She ain't going to waste her time on Whitney. She ain't going to do it. She's going to go to Teresa. And she's going to see if Teresa's going to be bad with her. So you're going to be searching out to see who's going to be bad with you. But it all depends on if you've got a good host cell. And I'll show you in just a minute how the virus replicates so quickly, because once we get infected, we start having signs and symptoms of what?
Cold. Flu-like cold.
Right, and so if we start having symptoms like that, what's going to happen to our immune system? Exactly. So our immune system is not going to be as strong. So Whitney thought she had a good immune system, but then she started getting a cold, or like thought she had a cold, started getting achy, started having night sweats, started being chilled.
So it's almost not impossible to get infected with HIV and not get it. I mean,
That's what I was.
it automatically kicks your immune system.
If you have the best immune system ever, will you still get it if it comes in?
Yes.
I mean, once you're infected, you might as well say.
Once you're infected, you are infected.
So it just sits around.
But see, the bad thing is
It takes.
how many, and we'll talk about this, well, I mean, I can go ahead and talk about it now, but the bad thing is when you get infected, do you know it?
No. So you're infecting other people.
So then now, here I am, I'm infected because I've had anal sex with 4 men. Okay? So now, me and that 4 men, Gosh, Miss Walker. We have now, those 4 men have now went on and had, each one of them had sex with 4 other people. And they had sex, he had sex with me and I was HIV positive.
Now you've given it 4 plus 8 plus 16, whatever.
Right. So I've shared with lots of people. That's one thing about an HIV virus. It likes to infect lots of people. And that's the sad thing about the virus. It is a mean, mean virus. All right, so we've got the understanding of how this is transferred. We know we've got to have the reverse transcriptase and the protease. We know we've got that. So, we got it?
Got it.
Maybe.
So the protein you said was the host cell.
Right.
Robin was the host cell.
Right.
So she holds the proteins somewhere for them to be separated. She wants to release that.
Both. Well, see, she was a host cell to begin with. Right. So it's both of them releasing it. So it's not just. Yeah, because she's going to have it too. I think I said just the host cells, but technically Amanda and Robin both are host cells.
So it kind of means them.
So the HIV has it too.
And the protease helps them divide. So I don't know really if it's just Robin releasing it or Amanda and her both.
Okay.
But you know you got to have it because it's in there so they can get apart. I think they look for anybody that they can find that will be bad with them. But mostly it is the CD4 and the T cells. T cells is who they want because they know the T cells are going to decrease the patient's immune system and I'm going to be able to knock them down quick. They are the fighters. They are the front line. You know, I think about Army. You know, they're the ones that, right, because they know that that ain't right. Amanda's not right. And so and I can think of it like this too, because Robin is looking, she's going to be the one that is on the front line, and when she sees Amanda being not right, she's going to try to go over there and try to make her right because she's part of the immune system and saying, okay, I'm going to start trying to fight you. And she's going to poke her, and she's going to make her be like her, when she was really trying to go help. her not be sick.
Somebody explained it to me like the virus is, you live beside the police station and the robber's gonna rob the police station and then come and rob you because they've already robbed the police station. The police station can't help you because there's no, they're busy dealing with what they're dealing
Right.
with.
So it's a pretty intense thing. But what I want you to understand is about the enzymes and about the CD4s, what happens to them, because they're not going to be normal CD4 people, and their levels are going to start dropping. Because you as a nurse are going to look, when you've got an HIV patient, you're going to be looking at CD4 levels.
The protease might come from both the original HIV cell and then the CD4 cell. What about the reverse transcriptase? Is that the HIV's transcriptase or is that the normal cell?
Normal cell has it in there. It has it in there, yes. So it's more like a combination, but know that you can't make the conversion without that enzyme. That RNA is not going to turn over to DNA unless you have that. Friends?
So they're not the same.
No. No, there's different. There's CD4 cells and there's T cells. They're like a family. They work together. They both try to fight off infection. Yes. They're both a form of white blood cells, and when you get in your mind of white blood cells and knowing that they need to fight off infection, then, see, Robin was really trying to help, but what she got, because she's not right. So, I'm going to fight off, and then they're going to pull them over and transfer it out.
So a CD4 cell has a certain DNA.
Right.
Okay, whenever it's infected with
RNA.
well, right,
CD4
RNA.
has RNA.
So whenever it's infected with HIV, it changes to DNA.
Right.
And that's what causes the changes in physical shape.
Right.
And
Exactly.
the protein sticking off.
Right.
Okay.
Exactly. With the reverse transcriptase and the proteins.
The protein's just released.
Yeah, just lets them go. So they can go out and Robin can go out and get you.
So, Ms. Walker, I have one question. I know that white blood cells typically have a lifespan, a very short duration.
Right.
So when they're transformed, is their lifespan increased?
Is their life, in other words, HIV, once it's infected with HIV, is it going to live longer?
Yes.
Yeah, I mean, I really
Or does it
can't
just
give you
die
a
off?
time frame of it, but I can tell you it will keep on going to try to infect other people or other cells as long as it can. And no, I do not know a time frame of how long it lives. That may be something I need to research, but it's going to keep on kicking. And it's going to keep on reproducing.
Because I know with cancer, once the cancer cells become cancer, they actually don't die.
Right. And HIV is sort of like that, but I don't know the time frame. I mean, maybe something I want to research. All right, so we got this. So now let's figure out how we're going to take care of these people. Oh, I got to go backwards. Okay, is that the right? Okay. So I've already said everyone who has AIDS has an HIV infection, but not everyone who has HIV has AIDS. The number, and this is how you're going to tell if they have AIDS. Let me make sure I'm to the right place next. Yes. Okay. The number, and this is what you've got to get in your little brains. The number of CD4 T cells or optimistic infections. That is a term that you need to know what that is. They're on page, I think it's 360. There is a list of opportunistic infections. There is a list. That helps us categorize what stage of HIV AIDS they're in. Okay, and that'll make sense a little bit more normal. Our CD4 level is normally 800 to 1,000. So you need to know what the normal range is before our CD4. Because what happens is, we already talked about that, CD4 is going to decrease, right, with our HIV patients. The bad thing about, and we just talked about this just a minute ago, the bad thing about the HIV virus, once it gets in the body, sometimes it takes up to 4 weeks to start showing me that I've got an infection. And when we go to the doctor, because we've got a fever and we've got muscle aches and we've got night sweats and we've got sore throat, we may even have a rash, what do you think the doctor's going to tell us? You got the flu. You got a virus. You might have mono because you've been kissing too many people. Or you might have meningitis. Are they thinking HIV? No. So this is where it is vital when we have a patient who comes in, and see, some people really get offended by this when they go to the doctor and they say, I'm here for a cold, and then the doctor's asking him about his sexual activity. And he's like, why is he worried about who I'm having sex with? I have a cold. Or is he worried about me injecting IV drugs? Why is he asking me questions about that? It has nothing to do with my cold. So there's a reason why through our assessment we're asking them, tell me about your sex life. Tell me if you have been injecting drugs. Tell me if you are homeless. Because our homeless patients have a tendency to be a little bit higher risk as well. So we've got to be honest. We've got to talk to our patients. Tell me about these things. And they get a little agitated. Oh, what did I do there? The bad thing is, and just like I said just a minute ago, I don't know what I've done there. What did I do up here? Oh, shoot. Will y'all please help me with this darn thing?
There you go.
Okay. The bad thing... Yep. All right.
He's acting a fool.
I don't know if I can go anywhere.
Okay, the bad thing is the war's already begun, hasn't it? Yeah. Okay, so my CD4 cells are already starting to take over. They are ready to take people out. They are wanting them to come with them and try to be ugly. My CD4 levels, is that something that the doctor usually tries to, or usually runs? No. It's not something that we run. But if I get more information from my patient in my history, then that may be, as a nurse, say, you know, as I was talking to the patient, I found out that he has done this or he has done that. It may be a good idea just starting out if we do a CD4 on him. And the good, or her. The good thing is, if that nurse is good on an assessment and starts saying we need to do a CD4 now, what do you think is going to happen when we start treatment? We're going to catch that virus early. We're going to be able to start that patient on the regimen that they need so we can slow it down. But the bad thing is, guys, it doesn't happen. It doesn't happen. And it happens after, I mean, it keeps going and the patient goes out, infects other people, and then he comes in and he's got another infection, and then we find out later, and it may be even years, before we realize that someone had an HIV virus 2 years ago and they have been infecting people over and over and over again.
Unfortunately, those questions are ones that people are not honest with.
Exactly.
Sex life and shooting up drugs. So, I mean, they're not a lot of times not going to be honest.
Right. In fact, they're not honest about a lot of things. Like my husband, I'm making him go have a colonoscopy done next week. And so I was filling out the history thing, and I got to the smoke, and I turned around and I said, how many packs of cigarettes do you smoke a day? He said, put on there, I don't smoke. I said, I am put on there that you smoke. He was like, no, you can't keep it in there. But that's right, they don't. And they're not going to be, because it's embarrassing sometimes. But if you establish a good rapport for them and explain to them, look, I want you, what you're saying to me is right here. It's not going anywhere else except to the physician, because the more honest you are with me, the better I'm going to be able to treat you. And it is hard for people. I know I've lied about stuff before, you know, to the doctor. No, I have never smoked a cigarette. Me, you know, or I've never, well, I better not go into things I've done. that might be a little bit. But anyway, so what's going to happen? So now they're infected. They've got the cold. We didn't do a CD4 level on them because we didn't think that it was even possible. So what's going to start happening? My CD4 levels are going to start dropping, and so then my patient's going to do what? Start having what? Lots of different types of that infection that I can't say. So as they get more suppressed in their immune system, so they start getting more and more infections. Now, so you know they're at risk for all those other types of infections. So the way I'm going to tell is if my patient is diagnosed with I probably should have put that up a little bit earlier. The diagnosis, we're going to do HIV positive. They're going to have a CD4 T cell count less than 200, or if they have a
Opportunistic.
thank you, infection. Once they have been diagnosed, because some people think, oh my goodness, I've got HIV and I've got AIDS, but through my medicine and through my treatment, my CD4 levels are coming up. So I don't have AIDS anymore. Once they have AIDS, they always have AIDS.
If they're being, that's a stupid question. I guess I already know the answer. I don't want to ask it. Never mind.
Well, ask it.
If they're undergoing treatment, they're still infectious to other people, so they still shouldn't
Yes.
go out and have intercourse with other people.
Right. Now, I'm not telling my AIDS patients not to have intercourse. I'm telling them to have safe intercourse. Right? Safe. I want to be safe. So, and this is a good point coming up, because aren't we going to be taking care of HIV patients that need education?
Yes.
They need it. Does that mean I'm going to stop talking to them about having sex? Do I want my AIDS patient to quit having sex? Heck, fire no. I don't want everybody to do it till they're 100. No, I mean, geez, it is a part of life, guys. Yeah, I just want them to be safe. Okay, I want them to be safe. I think everybody should be having sex. Secured everything.
So really the only time that they're diagnosed with AIDS, once their T cell or their CD4 cell goes below 200, they have AIDS.
No.
Okay.
Give me just a second.
Okay.
All right.
Got a question.
This is gonna sound really stupid, but I know you say like everything stays between you, the physician, and the patient, but at what point does it get reported to public health? Because, yeah. And at what point are we asking who your recent partners have been and notifying recent partners?
Once they get diagnosed,
with HIV, AIDS, I mean, what's the line?
it usually gets HIV as soon as they're HIV. Then we start. We don't wait till they get full blown.
Right.
We wait until. But yes, it is a confidentiality thing between the patient and the physician. But after we have the diagnosis, and then we sit down with them and say, look, this has to be reported to the CDC. So, yeah. And I can't tell you exactly on the 5th day of when, yeah, you see what I'm
No,
saying?
you're
But-
fine. I'm just looking at it from the, if we're lying about smoking, we're probably not telling every
Right.
sexual partner that anybody's ever had, hey, look,
Right.
I might have HIV, let's hang out.
Right. And we also have to look at telling them to be responsible. If you don't want me to contact them, then you need to contact people and say, look, you know, we had intercourse 10 years ago. I have now, you know, whatever, you know, we had intercourse, so now I have got HIV, don't know when I was infected. Just want to let you know, you may need to go get checked. So I encourage people to do their own contacting. I don't want to contact. Yeah, because that's going to be, obviously they're not going to be honest with me. If I call up and say, you know what, this is Leanne Walker, I'm RN. I heard you had sex with Holly 4 years ago, and now she has HIV. You may need to go get checked. Yeah, it's a little.
In our office, they have to sign a consent when they're
Right.
doing the blood draw, and in that consent, it lets them know that if their test results come back and they are in fact infected with HIV, that it has to be reported to the CDC, and then they actually contact them. So it's kind of like a consent release. So it's
Right.
not saying that everybody in the world's going to know, but it does go to them because it's more of a statistic thing, and then to let.
And you know,
everybody
even at the hospital, you have to have a consent form to have patients tested for HIV.
Yeah.
And how many patients read the consent form?
None.
None. Yeah, we go in and say, hey, you need to sign this right here. And they're like, okay. And we just say, oh, it's just because we're going to test you for HIV. Whereas we need to be saying, and if it is positive, this is what's going to happen. So maybe we need to be the ones reading the consent form as well, so we can educate the patients and tell them, if you are positive, this is what your next step is. So thank you for bringing that up. I didn't think about that. All right, so now this is how we diagnose. Oh, this thing's going to drive me to drink. Okay. All right. Now let's look at the different labs that we need to do to get a confirmation of HIV. One of the first things that we do is the ELISA test, and that is the enzyme-linked immunosorbent assay. That is the ELISA. So when the patients come in and we have done these tests to see, the ELISA is the quickest. Did I go in detail more later?
Way later, like towards the back, later.
I can tell you this is not the best job I've had on my little getting stuff together. I don't like it. You know when you do something. Alright, so I'm not going to describe these yet. I'm going to go ahead and tell you these are the ones, the Western blot, the CD4 count, the present. This is probably what I want to tell you more than anything. The presence or absence of, there's 26 AIDS defining conditions. It doesn't mean they have all 26. Okay? On page 360, there is a list of some types of the infections that they can have with AIDS. To make it an AIDS diagnosis, and we'll talk about this in just a little bit more, you have to have had these tests done and at least 2 to 4 of these issues on page 360. So what's going to start happening is once you start getting the ELISA done, then you get the Western blot done, and then you look at the CD4 levels, you're going to be able to tell which stage that HIV patient / AIDS patient is in. Okay? You will not get a diagnosis of AIDS until your CD4 level is less than 200 and that you have 2 to 4 of those infections. Off that list on 360. If you want to look, if y'all brought your book, you look on 360, there is a whole list of these problems, like cervical cancer, encephalopathy, herpes, lymphoma, MAC, PCP, there's a whole list of those things. And let's go to, that's the PCP. Yeah, that's the type of point, and that's exactly what is specific for patients who have AIDS. That type of pneumonia is. Now, the other type of pneumonia, MAC, what we'll talk about in just a little bit, is not specific. It is seen with AIDS patients, but it's not specific for AIDS patients. It is also seen with people who dig in dirt. So, which is really strange, and we'll talk about that in just a little bit. All right, maybe I can get down here to this classification here. All right, stage 1. The way we figure out if the patient has, at the very beginning of stage 1, is that they've had the confirmed through the ELISA or the Western blot. Their CD4 levels are greater than 500. You're going to be possibly given a situation where you're going to have to figure out which stage this patient is in. So if I've got a patient who had a positive ELISA test and their CD4 levels are 600 and they have no other kinds of infections, that patient is in stage 1. So we stage it accordingly to the CD4 levels. That's one of the major ways that we tell if our patient, this patient right here, does not have AIDS. You with me? Mm-hmm. Why is he not having AIDS? Because it's not less than 200 and he doesn't have any more infections. So he is in stage 1, HIV. Stage 2, got my positive ELISA test or my Western blot, but look at his CD4 levels. They're between 200 and 499. Is this patient have AIDS yet? No. Does not. Does not have. We are still HIV positive. It's not less than 200, and he doesn't have any defining illnesses. Other infections. Stage 3. HIV through positive test, ELISA or Western blot. Look at this CD4 level. Less than 200. And documented AIDS-defining illnesses like lymphoma, like cervical cancer, PCP.
So what does the percentage have to do with, like, the day? Does it matter?
No, I don't. They just put it in your book because 9 out of 10 times when you have results, you're not going to have that percentage. You're going to have the CD4 levels, the count. And the biggest thing that you want to remember is if it's less than 200, that has made my patient have AIDS, and he will have they will have other types of illnesses that makes it. So we have to look at that. Do you see how important the CD4 level is with an HIV patient? If you are given a sick situation, how are you going to decide which stage this patient's in? What are you going to first look at? You're first going to see if they've got a positive ELISA or Western blot. Then you're going to pull up their CD4 levels. If it's greater than 500, what stage? 1. Between
2 and 299.
201 and 499? 2. 3, less than 200, and they'll have what? AIDS. They'll have AIDS and they'll have other infections. God, y'all are good. But you know what? I'm seeing more than anything, and I can, and y'all gonna think I'm crazy when I'm saying this. How many people read? Yeah. Red. Raise your hand. I can see it, guys. I can see it. Even if you read my PowerPoint, I can see it in your eyes. I can see it with your If you read, do you need me?
Yes.
Yes. You better say you need me.
So, at stage 3, they're diagnosed with AIDS.
Right.
Okay. If they have a cell count less than 200, but they have not had an infection as of yet, they're still taking stage 2. Even if their count is less than 200.
You gotta have, for them to have.
But they're still at stage 2 if they have not had the infection.
Okay.
Yeah. If you've got a patient who has a CD4 of less than 200, they're going to have an infection. But I don't know that I would go and say, you're not AIDS yet, let me get you one more thing. I can say you're absolutely close, but to confirm it would be the other infections. Does that make sense? To make the confirmation would be the other two out of the 4, yes.
On those illnesses that are like listed in the book on that list, is there anything that could like mimic the HIV and the AIDS to decrease the CD4 cells, or is that just like this test is only specific for HIV?
Specific for HIV. Okay. There are some other diseases that may give you an abnormal CD4 level, but it ain't going to be the best disease. Does that make sense? Is that what you're asking? Did you hear that? There may be some CD4 levels that you draw on someone that may not actually be an HIV, but it's going to be higher than 200. It's going to be, 500, 600. Okay? So it may, but it's not going to be anything like 200.
Stage RSV, the illicit testing is used for that too. Is that still looking at CD4, but it's just a higher number?
RSV.
Other stuff besides.
It does check with RSV, but I'm not sure exactly. I know you're not going to drop it like you're going to drop it in this. I would say it may be, 600, 500 maybe, but not anything like 200. Is that what you're asking?
Yeah, so I mean, if you less than 500, that could be like, it might look like a stage that hasn't had the other symptoms too.
Yeah, the other symptoms or the other problems. Right. Yeah. Right. Okay. So stage 4, we don't really. This person comes in and we don't really have any information about them. I don't know why they put that in there. I don't even look at that. So just don't even look at stage 4 because that makes no sense to me. 13. Right. So don't even look at that. I don't even know how to do it. I didn't understand.
Big X to it, right?
Big X.
Ain't gonna be on test.
Ain't gonna be on test.
All right.
All right. Do y'all need a break? Yes. Hell. All right. Progression. Progression.
Progression.
No, I got a bunch I need to go through too. Y'all bring out, show y'all. All right, progression of it. HIV to AIDS. It can be months to years. It depends on how you got it. What other kinds of personal factors play into it. And one of the biggest things is how do you respond, or how do you stay in your treatment plan? I guess that's a good way. Interventions. What type of interventions do we do? If we have personal things like if you are continuing to have intercourse with someone who is HIV positive as well, then that's going to increase it, your risk. That's going to make it work or make you be infected more. If you continue to share needles, that's going to make it do more or make it move faster. So there's all kinds of things that you're going to see that may make this thing progress quicker from the HIV to the AIDS. This kind of stuff I don't like to talk about. Mortality rate, no court. We've already talked about that. We need to know, and I think all of you have been well aware of how and where HIV viruses are found in body fluids. They are in blood, semen, vaginal secretions, breast milk. A lot of you may not have realized that it is in breast milk. So one of the interventions that we would do for HIV mom that just delivered her baby would be what? Don't breastfeed. Do not breastfeed. Amniotic fluid, urine, feces, saliva. There's a lot of research that says it's not in saliva and not in tears. It is. Some of the books say no. Some of the research on the internet says no. Your book says yes. Yes. So that's what we're going with.
So they don't need to share drinks or spoons or...
You cannot transfer it that way. Okay? Unless you have, and you're right, Adam, unless you've got a sore in your mouth, it can be that way. Now, I know one thing, I was taking care of an HIV patient who had a trach, and when he went to cough, his sputum went in my eye. And so that's probably the least way that you can get contaminated or get infected with HIV. But I did have to go on the prophylactic, and I did have to do everything I was supposed to do of the medications for 6 months. But anyway, that's why I say, with tears, and I don't think it's in sputum, but
That's always where you've got.
yeah, just if you have anybody that you're doing a trach on, don't lean in front of them like this with nothing on your face, because when they cough, you will get sputum in the eye. So it is found a lot of places. Going backwards again. There has got to be another way for me to do this. Alright, here we go. Transformation, or is transmitted by. I'm not reading all of these to you. That's pretty self-explanatory. You can read that, right? Any question about that? I'd rather get to... it is not transmitted by casual contact in the home, school, or workplace. Now, I know everybody's going to say, well, what if you're talking about our workplace? Yes, it is. It can be transmitted in our workplace, where we work. But that's literally talking about if you were just in contact with someone. Now, there is always a possibility of you having a cut on your finger and them having a cut on your finger and that kind of stuff happening. But I can tell you, in our workplace, you are to protect yourself like everyone that we take care of is HIV positive. Okay? Always protect yourself. Sharing utensils, towels, linen, toilets cannot be transmitted that way. And your book actually says no mosquitoes or insects are transmitting. There's still some more research out there, but for this purposes, I've got to say what your book says. Okay? Will you mark that out? You can leave it in there if you want to, but I've already put the clinical manifestations in there. That was one from last year's, so we've already talked about that anyway. All right, sexually transmitted. We're talking about how it's going to be transmitted through sexual activity. And if you remember the ABCs of safe sex, this is what we have got to teach our patients. Not just HIV positive, everyone. everyone, we have got to teach them. The biggest way is abstinence. Now, I'm sorry, but abstinence is probably not going to work. Okay? So, I can say if I really want to teach abstinence, what type of people would I teach abstinence to? Our young kids. Okay? Our young kids, I need to teach them that this is the way. That's the way I taught my kids. It didn't work, but I taught my kids, not with my son, but it didn't work, but I taught him that. That's what I said. No, this is the way it's going to happen, and that's what we've got to reinforce to them. And I don't want to go in and say, you know, hey, you can get AIDS if you have. I want to teach them the importance of abstinence, period. Being faithful, not having 25 to 30 partners. I'm not going there either. Condoms. Please, please teach people to use condoms. And even when my kids were growing, or my son was growing up, he was like, you know, I try to, you know, you gotta do this, you gotta do this, you gotta do this, and he's like, you know, it just doesn't feel good that way. I'm sorry. You know, we've got to protect people. You are going to make people sick if you don't protect yourself.
It's not going to feel good when you get AIDS either.
Exactly. Exactly. So this is the best way that we can teach our clients, and we will stick to our guns and teach this type of material to our patients. If they abide by it, that's wonderful. If they don't, there's nothing we can do about it. Anal sex is probably the most risky, not just for men, but for women as well. Okay, you've got to understand that that is an area that is not usually penetrated. So it's not the fact of it is when it is penetrated, there are areas that break and the skin breaks down. So that's where, and then if it bleeds, then the semen is released, and then the semen gets into the bleeding areas. That's where we got the problem. So that is an area that's very, very risky as far as the transformation of HIV. We'll talk more about the viral load in just a minute. You know, guys, that our patients who are IV drug users are another high risk for this type of disease process. But it's hard to go and tell somebody, stop shooting up drugs. You know, that's something that that's not going to help. Yes, it would help them. But 9 times out of 10, it's going to be hard for them to do that. So what I think is very important is that we teach them ways to decrease the transformation of the HIV. Yes, I want them to go to hell and get off IV drugs, but I need to give them other things that I can talk to them about. Like, one of the biggest things that I did like about this book is it was teaching them, carry some water with bleach in it if you're going to share needles. Most patients that are IV drug users don't have a lot of money. And that's why they reuse their needles, because they don't have the money to reshare, to go out and keep buying it. So tell them, clean it with bleach. Let it stay in there for 30 to 60 minutes. So they should carry a container of bleach with them if they're going to use these IV drugs. 7, that's okay. Yeah. No, they ain't gonna like that little right.
Throw it in there and leave it in there.
Leave it in there. It ain't gonna hurt if it stays in there 30 minutes. I mean, you know, hopefully it'll kill everything. But we've got to keep them educated as much as we can. We also need to reinforce to people that all donated blood is tested for HIV. So many people are so afraid right now to have to get a blood transfusion because of the risk that happened several years ago. But we got to reassure them that the blood is tested. But there's still a possibility. Even though we can reassure them and say, okay, it has been tested, but there is a minute possibility that it still can be transferred that way. That's why you are seeing more and more of autologous transfusions, and we talked about that in OR. You're seeing more and more of those types of transfusions. Perinatal, that's my mom's. I had a girl that I was with her with all 6 of her babies. After each one, begging her to not have another one. But she was HIV positive. And the percentage of it transferring to the infants is, you know, it says 25%. I still think it could be higher. And this mom was not on medications. She was not on any medication, so it said 25%, but she had 6. The first one did not. The second and the third one did. The fourth one did not, and the 5th and 6th did.
Wow.
So that percentage is pretty high.
Wow.
Luckily, at the 6th child, after she delivered, she finally sat down. I sat down with her and said, look, come on, girl, let's tie your tubes. So we finally got her to tie her tubes after 6. So I'm not one that likes to test you on percentages of stuff happening. So just know the biggest thing with the perinatal transformation or the transmission is if they're not on drugs, the percentage is higher. So if they're not on the medication, so I want to do everything I can possibly do to decrease that chance of it happening. So if I've got an HIV patient, I want to have them on the meds, especially if they're going to have a baby. And that will increase or decrease the risk of them transferring it. Do not breastfeed. We have to highly, highly discourage moms that are HIV positive to not because if they didn't transfer it perinatally, there's a high possibility they can do it breastfeeding.
What if the baby is HIV positive when it's born? Will it hurt her to breastfeed her?
No, since it's already. But I have. Depends on how they're treated. If they get started, if we know right off there, I mean, I'm not going to say they're going to live 55 years, but I can say they're going to have a better chance if I know and I can get them on meds right then.
And they'll be on medication for
the rest of their life.
How exactly is it transmitted through breast milk? Will the baby have to have a cut in its mouth for that to happen?
No, it's formed in the breast milk. So HIV virus is in the breast milk. So once they secrete it,
kill it?
HIV.
What was the question?
I guess it's just a different fluid than saliva.
Yeah, it's different, and it's got the virus in there. So it's.
But with everything else, there has to be blood to blood or something to blood.
Right, but it's in breast milk.
Is it because the immunity is passed through?
Yeah, the antibodies.
Well, the other thing you got to think about is that baby's immune system is not fully mature either. So, but I will have to say this, and we're getting. I'm never going to get through with all this. I will have to say this: the majority of moms that are HIV positive and deliver children do not generally want to breastfeed. That's not judgmental at all. I'm just saying they're probably IV drug users.
And they don't care.
And because I think breastfeeding is a very intimate thing between mom and baby, and I just don't see them doing that.
You said that an HIV mom breastfeeding an HIV baby wouldn't harm them, but wouldn't it make them HIV worse?
Yeah, it's going to increase the viral load. Yeah, I mean, if the baby's positive, then we're just adding more viral load to it. In fact, and just like another way of being infected. So, I mean, it's going to happen. They're going to be positive. They're going to they have it. So, it's just making the viral load go up. Yes.
I guess this is a dumb question, but most bacteria or viruses or whatever derive from somewhere. Okay, like it don't just show up. How did it? How does it originate? You know what I'm saying?
Where did it originate?
I mean, because it's not contagious, like airborne or anything like that. So
It's very contagious.
right.
But I can't
Through blood,
Right.
stuff like that. But how did it, where did it come from?
I don't know. Exactly. I think so too. Yeah.
You're supposed to tell people that you have not and you're choosing to do that to your own child.
Child abuse.
Yeah, exactly. Yeah, that's
Have
harder.
people been charged though? Like if you knew you had HIV and you spread to a bunch of people, haven't you been charged for
Yeah,
attempted
and
murder or something?
It's been like, that's what we were talking about earlier. There's several cases that this guy knew that he had HIV and he was going around and just threatening everybody, and he should have got life in prison, but I don't think he got the like house arrest.
Like attempted murder.
Yeah. All right, let's redirect. Okay. Us. Oh my gosh. Us. We are at risk, guys. We are at risk. Why do you think we now have the angiocasts that retract the needle? I got stuck many times when we didn't retract because the angiocasts used to not retract. Yes. So it is vital that you have, any time that you are having any contact with any sharp object, that you're any needle or anything, please discard it as soon as possible, especially if your patient's HIV positive. That's why we don't want you recapping. We want you to get rid of it. And as soon as you're starting your IV, click that button and retract that back and get rid of it. Now, if you are stuck, you will have to go through protocol, and I'll show you that protocol in just a little bit. There's also, it is about half time. Page 264 is a chart for best practice for healthcare workers. I want you to read over that. I cannot stress to you enough about standard precautions. Just like I told you earlier, every patient that you have, you treat them like they are HIV positive. Every one of them. Testing, we talked about that, but I didn't go in detail about this. Let me see. I want to get to the test. It's not where I want it to be. I'll just have to go back. I want to go to the test. Where is it at? Okay, here we go. All right, we talked. Okay, antibody testing. We talked about that. Remember that the antibodies usually are made within 3 weeks to 3 months after the infection occurs. So doing a CD4 right when the patient is infected may not give us accurate reading. And the bad thing is that it may take up, and I said this a while ago, it may take up to several years to get it to come positive. The biggest test that one of the first tests that you're going to see is the ELISA. We talked about that just a little bit ago. The bad thing about or the good thing about it is it's very quick and it's cheap. So that's the easiest way. The bad thing is it may be done during a period of time that the patient has not built up enough antibodies to give us an adequate count. That's the bad thing. So we may do it and they may come out to be a false positive or a false negative, and it's because of the time that they were infected. So at that point in time, that's not going to give us a lot of results that we can do with, or to help us with the treatment. So, and it may tell us that it may still tell us they've been infected, but it may not give me an idea of if it's true reading. So that's the first test. Dang it, poot. I gotta find that. Why is it going backwards when I'm doing it the right way?
If you're on the computer and you scroll down, you're actually
Me and this thing, I'm tired of fighting this. All right, where am I at? All right, Western Blot. That is the most reliable one. It's used to confirm. And what we usually do is we have done the ELISA, and once it's positive, we then have them do a Western blot. So we're never going to just go on the diagnosis of the ELISA. Once you have an ELISA positive, then you will go to the Western blot. The bad thing about this is very, very expensive. So I need to make sure that there's a reason why I'm doing this test on this patient, because I don't want them to have to pay for it. It actually detects the antibodies to help it show up to be positive. Now, I don't want you just to so concentrate on the 2 of the 4 antigens. That is not important. I want you just to understand that the Western blot is used to confirm the diagnosis of HIV, and it detects antibodies. Okay? Just for HIV, don't worry about if it's the AIDS, because the AIDS is going to be diagnosed with what? CD4 level. Exactly. They are coming out with an oral testing HIV antibody test. I have not actually seen this myself, and I do not know if it's anywhere around here, but it's really neat to have this if we have it, because we can get the results back in 20 minutes.
That's the one that you buy from the drugstore? What about the one that you buy from the drugstore?
Yeah, I think that's sort of like this. I have not actually, maybe I'm saying I had never seen it in a hospital setting. So maybe that's something that they're doing like over the counter, that you can go and get the results like a pregnancy test that will help you diagnose and see, which is good, because if you know right then that you were possibly infected, and then you could go get one of those tests, and if it came back at least a little bit positive, and you go get treatment, then that'll be perfect. Wonderful, because we can get you on meds, and then we get you on meds, and the meds will stop the replication of the
RNA to DNA.
RNA to DNA. Woohoo! Very good, very good, very good. All right, viral load testing. That is where they actually test if there is HIV genetic material, which would then be the RNA to DNA. You can actually test that protein to see if it's positive in the patient's bloodstream.
And that's how they test blood that's donated?
Yes. That is one way that they check. They test every blood transfusion for viral load. That is one of the first things, that is one of the tests they do. They do many more, but that is one of them. This is also going to tell me, is the progression of the disease getting worse? But the best reason, I can't stand being up here in this corner, it's driving me crazy. Now y'all can put on my evaluation if Miss Walker threw a fit. I've been Walker throwing a fit. Okay. The best thing that this is going to tell me is if the treatment of this patient that we're doing is working. Because what I want to see happening is that viral load when the patient's on a regimen. If I see the viral load going up, what do you think that's telling me? That meds are not working. So what do we need to do? We need to adjust them. If they're going down, it's working, right? So I got to see with that, if the viral load is high, it ain't working. I got to try something different. So, when I go to the meds, let me see where I am with the meds, because that's what I really want to cover real quick. like, where am I at? Okay, so I need to keep going. I'm going good. I'm going good. All right, so that, I want to do meds. Knock that one off, because that one's out of place. Sorry. Exit out, it's not even, I mean, we talked about it earlier, but that's from last year's. I didn't delete it. Well, it's on another slide, but it's in the wrong place. This is my nursing diagnosis. I'm not talking to you about nursing diagnosis. All right. Of all the things that is so important about taking care of a patient with HIV is to decrease infection. That is the most important thing I've got to do. Whatever I can do to help decrease infection. So my plan for one of my nursing diagnoses, Jason, is going to be preventing infection. We know that my patient has a deficit in his immune system. So I want him to make sure he doesn't have fever, chills. Now, how many of you would call the doctor just for fever and chills? Very few of you. My HIV patients, they need to call somebody. They need to know that we need to catch it at the beginning. I do not want them going a day if they notice that their fever is coming up and they're chilling, or if they have diarrhea. These are my goals that I want for them. So I've set goals for every one of them, and for all my problems. So y'all need to take note of that. All right. Trying to see. There's several things that you don't think about when you have this type of patient that is so deficient in their immune system. And it's almost like your cancer patient. So maybe you've talked a little bit about it, that there's things that you need to make sure that you keep away from that patient. One of the biggest things that you look at is, I mean, we want him to eat fruit, right? Mm-hmm. But fruit is not something that I need him to be eating without doing what? Washing it. In other words, a banana is an excellent resource of potassium. And a lot of times if they've had diarrhea or if they've had throwing up, then I need to replace that potassium. I want them to eat bananas. But how do I help him? Every person that is decreased immune system, what should I be doing because I want them to have a banana? Wash the banana?
Wash their hands. Wash their hands and them.
Peel it for them. Can't I wash my hands real good and peel it for them? What am I not wanting him to touch? The outside of it with all the pesticide and all that stuff on it. So easily, all I've got to do is peel that for him. Okay? I do not want him to be being exposed to anything like that. Fresh flowers is another thing. That is one patient that should not have any fresh flowers. Now, what do we want to do when people are in the hospital? Go get flowers. We don't want to do that. Other thing that we want to do is make sure that they do not empty any type of cat litter boxes, because cat litter can cause the MAC as well, the bad respiratory infection. So we do not want them doing anything with cat litters. We need to keep them away from people, a lot of crowds like churches, and I want them to go to church, but that's probably the worst place for them to go because there's so many people. And you know what they need to report? All right, let's do the drug therapy. This is so vital. If I say it one time, I'm going to say it 500 times. So y'all will get this. To treat an HIV or an AIDS patient, you do not want just one drug. It is going to be a combination of drugs. So we do not, and just like I wrote up there, it does not help the patient. I'm going to give them a combination which is called HAART. H-A-A-R-T. And that is highly active antiretroviral therapy. Did we say retrovirus earlier today?
Yes.
Okay. So does this mean that if I give my patient these, then he's not going to have the HIV virus anymore?
No.
That's not what it means. What it means is that I'm going to, with these drugs, as I give them to them, it is going to inhibit viral replication. What does that mean?
The transfer from RNA to DNA.
It's going to inhibit the transformation of the RNA to the DNA in the cell. So if I decrease that, what type of results do you think I'm going to see with my patient? Huh? I want to see an elevated CD4, right? Or an improving CD4. I want to see it go from 200 to 300, 400. So I want to see. Or is my viral load going down? That is the indication of what we're going to be doing when we give this patient this combination of medications. That is what I'm looking for. I need you to understand that you cannot kill this virus. You cannot stop this virus or kill it or cure it. We just want to stop the replication. And the only way we can do that is through this combination of medications. If your patient misses a dose, what is that doing? Exactly. Giving that virus a chance to replicate, and so the virus or the disease process is going to get worse. It is vital. They cannot miss these drugs. All right, the first, geez Louise. All right, the first one are our nucleoside reverse transcriptase inhibitor. Where do you think that's working at?
Reverse transcriptase.
With the reverse transcriptase, exactly. So, it's trying to make, actually, I like the term full. Well, my daddy used to tell me that's not a good word. So that's probably not one that I would... Trick. Let's say trick. Good. It's trying to trick that reverse transcriptase into not transversing or converting that DNA, that RNA to the DNA. So it's sort of trying to say, okay, you are not going to make this connection or make this transformation. I'm going to trick you, and it's going to make like a different type of host cell. So with this medication, the replication of the RNA to DNA will be suppressed. That is what every one of these drugs do. But they cannot do it alone. I have given you a list of them. There's several in your book, but I just stuck the ones that are the most common and the ones that are seen in the Netflix books. So those are the only ones with this category. This is the ones you need to know for that. The Xeret is not seen a lot, except for patients who cannot tolerate AZT. AZT is the most common one that you're going to see, and I can bet you're going to see that one again.
I had an AIDS patient that I took care of, and they say that you're not supposed to touch that medication.
Right.
Is that correct? I mean,
exactly. I usually take the pills and either pop them in their hands, just take them straight out of the thing, or I take them in a cup and pop them right over it. And the pharmacy will write on there, do not touch.
Because the patient had dropped one.
Oh, yeah.
And I went to pick it up, and she's like, no, keep that out of your, go get your gloves.
Exactly. Exactly. We do not want to touch any of those drugs. It's just the chemistry thing in it, and we can absorb it through our fingers. Just like nitroglycerin, when you do the patches, how you take it off and you don't touch it, you can absorb it through your hands. And you don't need it because you don't have any, well, hopefully you don't have any HIV virus in your body that's trying to convert. All right, now these are the non-nucleoside reverse transcriptase inhibitors. These are only given to HIV patients. Only. And they inhibit or suppress viral replication. You shouldn't have a problem with the different classifications because they are all retroviral. Exactly. They're all antiretroviral, and they're all suppressing viral replication. And there's your list of theirs. Here's your protease. Now, that is an anti-retroviral as well, but that one works on the release of protease. Remember, protease is the one that is excreted when they makes the final breaking off to go out. So this one's going to work where the other ones are going to work with reverse transcriptase. This one's working with the protease. So it's going to block that production of it, or enzyme.
So if the virus sticks to the cell, it won't release. But does it still inject its proteins and both of those cells stay together?
But that's the reason why you want to have a combination, because the two combinations that we just talked about are going to block the reverse transcriptase.
So basically, one don't work, the next one might work, the next one might work.
Right. If those two drugs are given and they're blocking the reverse transcriptase, then there's no reason for that protease to be released. But I still want to make sure I give that medication just in case it doesn't block the reverse transcriptase and one gets by. Let's say the dosage is not correct. It's not high enough. It's not strong enough to do every cell. It does some of them. But then how would I know if it's not?
Viral load.
Through the viral load. Exactly. So that's why it's very vital that this patient gets their blood test all the time. And they take every one of these drugs together. The fusion, we talked about the fusion. These medications inhibit that fusion of it. So here's another part of what we just learned about earlier in the different stages of the replication of the virus. Each one of these steps, there's something that happens. And these meds, as a cocktail, are going to block each one of those processes.
So that's the whole point that they're going for each step. So you're trying to step happening all.
Exactly.
The next drug.
Exactly. So that's why it's important for you to do the combination. Can you see where just one anti-retroviral gives in there is not going to work, is it? Because it'll go through and then it'll start up with the protease, or it'll start. So I've got to make sure that I hit every step of those processes and what's going on in the whole kit and caboodle of it.
Is there something like a protein or enzyme that attracts HIV, the virus to the cell, or is it just random?
Random. It just meanness. That's the way I look at it. It's a mean little cell. It's trying to get everybody else in trouble. Now, I will have to say, I'm not familiar with this drug right here. This is a very, very new drug. But what it's, I mean, I understand why the other ones are being given because of the things that are happening within the cell. But what I'm seeing, what I've read about this medication, is that this is going to try to help build or decrease infection. Because remember, if you have patients who have HIV, are immunodepressed, and they have, this is going to help us build up immunities so they won't get sick. Now, I have to admit, I have not researched this like I want to. So, know that this one has helped prevent any type of infection. All right, where did I go from here? All right, now, the other, I am not going to keep going back into the, oh, did I miss the band?
The integrase.
What do you think that one works with? Protease and integrase are about, they have the same type of activity, in other words. So that one works more on trying to get rid of the proteins on the outside of it. This is fairly new as well. And, you know, everybody, they're doing more research. And, you know, that one slide that I said, this is probably not understood very well. This is what this drug is going to start working with. So this is new evidence-based practice that they're trying. So I don't want, I'm not going to, I'm not, in other words, I'm not seeing this on the NECLEX at this point. I want to introduce it to you, but it's not written in stone from the NECLEX yet. But it's in your book. All right, let me just sort of look at what I missed. Okay, we're doing good with understanding the process of it. We understand the different stages due with the CD4 level, right? We're good with that. You understand the different types of tests, the ELISA, the Western blot, and the viral load. We know why we do the viral load. We know how it's transmitted. We know how to teach them the ABCs. Correct? All right. I have listed a couple of the infections that you will see with a patient who has HIV. The PCP is one of the first ones that you're going to see most common. And that is that pneumocystis, pneumonia. Patients who have HIV, when they get, or they come into the hospital because of their decreased immune system with pneumonia, it is this type of pneumonia. The biggest thing that brings them to the hospital or brings them to call the physician is they say, I am having shortness of breath on exertion. That is one of the biggest things that we teach them when they're in the hospital. If you start, and they usually notice it when they get up and go to the bathroom. They've been fine, and then all of a sudden they start getting short of breath when they get up to the potty. That is when they need to let us know. They need to call the physician at that point. Hopefully we can get it before the pneumonia gets too bad. But that is very, very specific for HIV patients. Candidus is another infection that you're going to see. Very, very common. Do you know what Candidus is? Thrush. It's thrush. It's a yeast infection in the mouth. So if they have a yeast infection in the mouth, what do you think is going to hinder and be a problem for them? Eating. So when someone has a decreased immune system, what do I want them to do? I want them to eat, but if they have sores, now how many people's had an ulcer? Patients who have HIV is not just, I mean, how aggravating is an ulcer? It's pretty aggravating. We're talking big mouth sores, guys. We're not talking about a little tiny ulcer. We're talking about the whole mouth full, all the throat full of ulcers everywhere. Nutrition is a major, major issue. I have got to get some nutrition in that patient. Ice cream is the best thing. Wendy's, Frosties, for an HIV patient who has candidus is amazing. Amazing. It's full of what? Calories, isn't it? Full of calories. And what do I want to give him? Calories. Plus it's soft and soothing through them. So give them lots of calories. The one thing that is I have seen over State Board of Nursing asking you a question about how are you going to treat a patient who has candidus of the mouth that's an HIV patient. One of the biggest thing is nystatin. I didn't see that in your book. Right. And I have a problem. It was not in the book anywhere. I read it and I did not see it. So I want you to know that nystatin is one of the best things that you can give a patient who has thrush or candidus and they're HIV. Wait, I don't even care if they are HIV or not. It's the best thing.
Is that Carafate helping?
Carafate, if they can swallow, really, really good. But Carafate does coat, but it's more of a GI. Yeah, it has to. Now, Carafate needs to be dissolved. You can dissolve that. Don't give it to them whole. You can dissolve it and let them take that. All right, so we've got the nystatin. The MAC, the Mycobacterium avian complex, that is very, very common too with your patient, with the HIV patient. And that is also the one that if you mess in dirt, if you play in dirt a lot, you may get that as well. But you will see the PCP and the MAC with your HIV patients with any type of respiratory issue. You know that they could get herpes. You know about herpes. The other thing that is, as far as what is very, very common is that Kaposi sarcoma. Now that is one of the malignancies that will help you assist in the diagnosis of HIV to AIDS. Kaposi, it is small purplish raises or rashes all over the body of the patient. I don't know if y'all have seen some of the models that are the mannequins in there that they have the blue purplish stuff. We were simulating Kaposi's on one of the patients. This is it's all over their bodies. There is nothing that you can do about it. The good thing that it doesn't hurt, even though it's a malignancy, it does not hurt them. So that's a good thing. And it's not really itchy. You would think that you have or some kind of rash or anything like that on you, you think it's very itchy. It does not. And it's not painful, which is a good thing. It's just very, very embarrassing for them to have that type of purplish little things all over them. So you may see a lot of cancer or HIV patients wear long sleeve shirts so they'll keep their arms and torso covered so no one can see that. But that is one that is very, very common.
Did you say that's for the HIV day?
Yes, that's going to be one that's going to help you in making that decision if they're HIV or AIDS, because that is a malignancy and it's on that list. Another thing that's very, very common for a patient who has is the dementia complex. And you'll usually see that as the ADC. There's almost 70% of patients get some type of dementia complex when they have HIV or when they have AIDS towards the end.
Why is that?
The HIV viruses have went to the brain, and they have started destroying all the normal cells and the CD4s of the brain tissue. And so you'll see a lot of
confusion with one of those.
Yeah, they get confused, and it's just the HIV has totally taken over every cell in their body.
It's a late symptom. It's a late sign.
Yes, that's very late. You'll see that late. All right. Now, I have given you interventions. I've given you all the medications. I have given you all the interventions of what you would do for a patient. I've actually, with each nursing diagnosis, I've given you your goals and your interventions. So those are what you need to be looking at as well. And I have given you the evaluation at the end. So I follow the nursing process through this. Now, I want you, I know that was very quick, but I found an amazing thing on YouTube. And it is, if you go to YouTube and go to HIV Full Edition.
Michael Myers.
I love him.
Yeah,
He's just like me.
He's wonderful.
Do you watch him all the time?
All the
Oh
time.
my gosh.
He is.
Wait, y'all tell me about him. I just found him.
He has a good one about
Yes.
Yeah.
I just found him. His HIV Full Edition is amazing. Everything that I said today, he's repeating it.
There's a website.
Huh? This man, what's his name?
Myers.
Michael what?
Myers.
Yeah. I just found him. Why didn't y'all turn me on to him?
He has a website that you can purchase, it's like per month.
Pay
That he does all
$15.95
kinds of stuff.
Why you want to pay when you can go on there?
They're not all of them.
Oh,
I didn't think it was full version was online for HIV.
it is HIV Full
Watch his immunity.
Edition. It is amazing. Everything that we talked about today is just a definite review. So if y'all, I can even show it Monday if those of you that didn't get to, but I would encourage you because that is going to have a good, like I said, this unit is very, very, very short. Very, very short. I can't believe I got all